Welcome everyone to today's webinar. I'm Brian Zimmerman with Becker's Hospital Review. We'll begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. We look forward to hearing your questions. We will also have a series of audience polling questions during today's webinar. The poll questions will pop up automatically on your screen throughout the presentation. When the poll question launches, please select an answer from the options on your screen and click Submit. Thank you in advance for your participation. This session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access the recording. And at this time, it's my pleasure to start today's webinar by introducing our presenters. Dr. Knoebel is a pharmacist serving as Senior Manager of Pharmacy, Health Analytics, and Drug Policy within UChicago Medicine's Department of Pharmacy. His work focuses on identifying areas of unwarranted care variation, medication formulary management and optimization, and overall value improvement. He has expertise in quality improvement and pharmacy outcomes research and analytics, with his research interests focused around safe and effective care delivery, with clinical interest in pain management, serving as Pharmacy Director of UChicago Medicine's Pain Stewardship Committee. Dr. Knoebel also serves as Residency Program Director for the PGY1 Pharmacy Residency Program and works closely with residents and students to emphasize research and quality improvement design and analysis, health system science, and implementation science. Dr. Bastow is the Pharmacy Senior Solution Advisor for Lemire. Her work focuses on partnering with pharmacy department clients across the country to help them leverage Lemire's integrated research, analytics, and formulary workflow platform to identify and implement cost savings initiatives that focus on the reduction of clinically unwarranted care variation. Prior to this role, she served as an emergency medicine pharmacotherapy specialist for several years in Florida before moving to Chicago to pursue a clinical pharmacy management career. Most recently, she was Director of Adult and Pediatrics Clinical Pharmacy Services at a large academic medical center in Chicago. In that role, she also served as the Chair of the Drug Shortage Task Force, a member of the Research Task Force, and the Residency Program Director for the PGY2 Critical Care and Emergency Medicine programs. She is also part of the National Drug Shortage Coalition in collaboration with the American Society of Health Systems Pharmacists, as well as a member of the Section Advisory Group for Clinical Leadership with ASHP. At this time, I'm pleased to turn the floor over to Dr. Bastow to begin today's presentation.
Brian, thank you for that introduction, and thank you everyone for joining us today. Let's see here. Today we'll be touching on three main topics. One is strategic approaches to identifying potentially inappropriate care variation across your health system. Also, clinical and operational interventions to reduce inpatient drug spend. And lastly, techniques for successful adoption of pharmacy initiatives by the interdisciplinary team. Before we jump into cost savings strategies, we want to share some data that kind of helps paint the picture of hospital drug spend. And first, we want to look at the state of affairs before the COVID pandemic. Here, if you look at the screen, we showed some data that reflects a survey of over 4,000 hospitals. This report was published last year by NORC, the AHA, ASHP, and FHA. And if you see here, just hitting some of the high points, they saw total drug spending per hospital admission growing by 18.5% just over that 2-year survey period. And they were reporting that payers were unable to keep up with the rising drug costs, which I'm sure many of you can relate to. They were seeing price increases of greater than 80% across many different drug classes, including very common ones like anesthetics, opioids, chemotherapy, etc. And over 90% of hospitals had to identify alternative therapies in order to mitigate the impact of drug price increases as well as drug shortages. What I thought was very significant is 1 in 4 of these hospitals had to cut staff in order to mitigate budget pressures. And of course, I think we're all aware that these shortages do place patients at risk, in addition to creating additional burden and costs to the health system. So that was before COVID. And so as you could imagine, this pandemic has now exacerbated many of the challenges that we were already discussing being, a part of that picture. And in fact, there was an AHA analysis that was published recently that looked at just a 4-month financial impact for U.S. health systems. What they found is that there's been an impact of over $50 billion per month across the U.S. And this could, be looking at COVID hospitalization costs, but also canceled revenues from surgeries and other, perhaps elective services. Also looking at the costs associated with purchasing PPE, not only needing additional PPE, but they're actually seeing an increased cost for these supplies. And of course, cost of providing additional support to the frontline staff. So there's a lot that's rolled into this. And it's certainly a significant impact that we're seeing. Pre-pandemic, the Congressional Budget Office actually projected that there would be a 40 to 50% of hospitals that would see negative margins by 2025. And now they're saying this is significantly exacerbated by the pandemic. So we were already in a tough spot, and now we're feeling the pressure even more so. In addition to that, bad debt and charity care had increased 13% over last year in March. And last point here is that drug shortages that were previously estimated across hospitals about $400 million a year are now being, of course, exacerbated by the pandemic for many different reasons. And the reason we just wanted to share, the last slide in this one is to, of course, highlight the issues that many of us are facing in the healthcare system. And we understand that departments of pharmacy oftentimes are one of the largest cost centers and are often looked to first as a way to mitigate the financial impact that we're experiencing today, and probably why a lot of you are joining us on this call. So what we'd like to do, just to kind of lay the foundation and get a better idea of who we're meeting with today as the audience, is just ask a couple of poll questions. So the first one, if you wouldn't mind answering this one for us, over the past 6 months, has your pharmacy department been specifically asked to further reduce inpatient drug spend? So yes, by a significant amount, or what you would consider to be significant, yes, by a reasonable amount, or something similar to what you've been asked to do in the past, or no, you have not been asked to reduce your inpatient drug spend further. So we'll go ahead and probably give about 30 seconds for those of you who are able to answer the question. All right, so let's see here. If we look at the results, it looks like about a third of you have been asked to reduce your budget by a significant amount, at least half by what you would consider to be a reasonable amount, and there's a fortunate few of you who have not been asked to further reduce your inpatient drug spend. So definitely looks like we're talking to the right audience today, and we're excited to share some information. With the next poll question, we just kind of wanted to get a little bit more in depth as to adding on to the previous question. So for those of you who answered that yes, you have been asked to reduce drug spend, do you feel that you have the opportunities and the strategies identified in order to achieve those savings and the goal that's been given to you? So yes, that's well underway. You've identified those opportunities. Somewhat, you kind of have an idea of where you're heading, but perhaps need to shore that up, or no, haven't really started to dig in yet to what those opportunities might be to hit that goal. And again, we'll give about 30 seconds for this question. All right, so the good news is it looks like most of you are well on your way to kind of figuring out, or at least have a starting place on the goals that you want to dig into. And then a lot of you had said that yes, or I'm sorry, quite a few of you had said yes, about 17%, as far as kind of having a clear idea of what you want to work on, and you know, about the same amount still at square one and looking for opportunities. So again, thank you for participating in that. We have one last question we want to ask. So what are the common strategies that you're typically using at your organization in order to identify these cost savings opportunities? And you can check all that apply. So do you look to target high cost medications? Are you receiving guidance by a GPO or a consultant firm? Are you using analytics software to look for this information? Perhaps are you focusing on cost per case of high-cost diagnosis or conditions? Or lastly, benchmark utilization against other peer institutions. So you can check all that apply for these. All right, great. So it looks like for the majority of respondents, targeting those high-cost medications is the most common by far. And then, of course, working through your GPO, perhaps using software, looking at high cost per case and benchmarking all seem to be very similar. Perhaps, you know, working through the GPO is a little bit more common than the others. So thank you all so much to those who participated. This really helps us to understand how to best guide our conversation today and provide examples where most appropriate. So now as we dig into the core topics of this presentation, we want to start by discussing care variation because this is one of the leading drivers of excessive spending and therefore, you know, a nice target for cost reduction strategies. And another way of framing this discussion is in terms of waste in health system, which can lead to providing lower value care, which Randy's going to dig into a little bit more detail in a moment. But in this article published by JAMA last year, they quantified the dollars of waste in the U.S. health system. And overall, they estimated that up to $900 billion is wasted annually throughout the system. And this makes up about 25% of total healthcare spend, so certainly significant. There are a couple of causes which we've outlined in this table, but there's two that I would like to point out because this will be our focus of today. One being the failure of care delivery, and one definition for this says that it is the waste that comes with poor execution or lack of widespread adoption of known best care processes or best practices. The other one is overtreatment or low value care. And combined, you can see that there's an opportunity to prevent over $100 billion in annual spend or annual waste just by targeting these two areas. And again, why it's the main focus of today's conversation. So what I'd like to do is turn this over to Randy so he can dig in a little further into talking about value in healthcare and the different strategies to target this.
Great. Thanks, Sam. And thank you all for joining this afternoon. As Sam has just planted the seed, in healthcare, variation is kind of the norm. We've come to kind of expect this. And despite efforts to introduce protocols, care pathways, order sets, checklists, standardized quality measures, variability in care is inevitable, it seems, and the variation even amongst providers can be pretty remarkable. Some of this variation, of course, is benign. In some cases, it might contribute to a poor outcome, and most often, or more frequently, it results in waste, so greater costs without really providing a better outcome. And so when you try to align value with what, for example, the Institute of Healthcare, IHI, Triple Aim, with, targeting population health, experience of care, and per capita cost, those three variables and kind of what Sam talked about on the previous slide all feed into this kind of elegant yet simple equation that I have on the screen here, which is value equals outcomes over cost. And drivers of outcomes could be quality improvement, could be efficiency, could be safety, and then cost could be direct costs, maybe dollars versus indirect costs like resources and time. I have on here patients first. You can't forget that obviously we all went into healthcare to take care of patients, and so making sure that we're always keeping that frame of mind as we approach these types of decisions. And so when you think about what are the influencers of value, it's not just evidence-based economics. I think that's pretty clear from the equation I showed previously. You have to look at both sides of the equation when you start to address utilization opportunities. And so obviously economics is one aspect that's fairly important, but also how does that maybe get addressed by evidence-based medicine? We know that it takes sometimes up to 17 years for evidence to actually translate into routine care. How do you shorten that? How do you shorten that window? And we'll talk about some ways and strategies that you can improve that. And then the last is quality improvement. We're never at a standstill in healthcare. Everything is always constantly changing. There's always better ways to maybe do things either from a technological perspective or from a process or people perspective. And so figuring out how do we continue to move ourselves forward and pushing ourselves to somewhat stretch goals in a sense to make our outcomes and our spend the best it can possibly be. And all of these things, one can't be done without the other, and they all also do independently drive value. So the way that I think about this, and many others have thought about this, is putting it into this framework around vertical versus horizontal. And it's a way to kind of address or think about how to frame an approach to identifying a potentially inappropriate care variation. So from a vertical perspective, if you want to think of each of these bars as potentially being a pathway for a condition or maybe even a specific diagnosis or maybe a specific patient care process, think of those as kind of being that. What's clear with any of these things, whether it's a condition, a diagnosis, a process, is that they're going to cross-cut multiple cost centers, right? So it could be pharmacy, it could be radiology, it could be supply chain, it could be laboratory, it could be all of those. And so understanding that, the complexity and where variation occurs could be within decisions being made within a specific condition, or it could be within decisions that are being cross-cut with these individual cost centers. The other way to think about this then is kind of flipping it on its axis where you look at horizontal. And so these are the cross-cutting initiatives across many different conditions, diagnoses, processes that might target specifically one individual resource that could be informed by expertise within pharmacy, lab, imaging, supply chain. And so thinking about what's my approach here? Do I want to maybe improve an outcome or reduce length of stay, or do I want to reduce cost per patient day for a specific diagnosis? Well, then it sounds like you're talking more about a vertical type of approach versus do I just need to reduce my drug spend? Perhaps now you're thinking about focusing on high-cost drugs that's cross-cutting multiple different diagnoses. And I think it's just important to look at this framework because it is complex. You're going to have to involve stakeholders from all the different service lines that drug might be used in, and vice versa. If you have a specific pathway, you need to involve all those stakeholders from the different cost centers that are involved to be able to influence and make the decisions in the most efficient way possible. And so to start with the vertical approach, one approach that we use is guideline reconciliation. So go to the guidelines. What does the evidence say? There's some compendiums that are put together, like Choosing Wisely, for example, which are a list of specific topics that would be considered low or no value care. And so how do you do that? Well, you can do this proactively through internal reviews. You might consider doing medication use evaluations, maybe comparing what a current practice is compared to what we would consider the leading practice. Or this can be done reactively, maybe looking or focusing on safety events. Maybe there's a trend in the wrong direction for your PSI 90s or hacks. Maybe looking at internal reports, maybe looking at getting some ideas from a morbidity and mortality review. All these things could potentially be a source of kind of creating that burning platform you need to get the work started. And so ideally, it's initiated potentially by a safety event, but ideally it's almost initiated proactively. But what you can do is create this crosswalk of a guideline recommendation, maybe, for example, going to the CHEST guidelines and looking at what are the elements in the CHEST guidelines and are we following those? And if we're not, is it justified? That might be a source of where you might consider focusing some efforts from a quality improvement perspective. You can pull institutional data to then help understand what the truth is happening and identify those gaps. If you do find gaps, you can put together interdisciplinary teams to update protocols or develop protocols where discrepancies exist, and then hopefully enhance those processes around those areas of deficiencies. Potentially you identify a bottleneck for getting access to a medication. Maybe you build some service around that so that you can augment that and improve the outcome. So here's an example. You can go to Choosing Wisely and select whatever area that you primarily work in. So since this is a pharmacy talk, or since I'm a pharmacist, here's an example where about 80 low-value medication-specific initiatives that are listed in there, and they're essentially dumped them onto this crosswalk where you have the society recommendation, the specialty, what the setting is it inpatient or outpatient, and what patient populations is it impacting, adults, pediatric, geriatric, maybe even specific service lines. And then you can put a status around, okay, are we compliant with that specific recommendation? And if we're not, how do we get there? Do we need to do an MUE? Do we need to get a team together? All this stuff. The other approach is looking at benchmarking. And so I saw in the results that about a little under half of the organizations use benchmarking as a tool. I think the question was specifically addressing external benchmarking. But benchmarking can be a very powerful tool for a few reasons. One, it can help reconcile perception versus reality. But it can also help lift up and maybe even provide some ammunition around creating urgency for reducing drug spend. So it's another source of data to kind of be a motivator. As I alluded to before, provider-to-provider variation is fairly common. In fact, we almost expect it to be the norm, which is why as Sam pointed out, there's an incredible amount of waste in healthcare these days. And so one approach could be internal care variation. So this is looking at the provider-to-provider variation. You could use data from health record, the electronic health record. You could use ChargeMaster data. There's a cool tool that I've just recently discovered called the Advisory Board Hospital Benchmarking Generator. I believe it's free to organizations that are already part of the advisory board, but it does provide internal and external care variation reports for Medicare patients specifically. And then you can use managed care reporting. But all this stuff, hopefully you can get down to that provider level to look at whatever your question is. Are we looking at a utilization opportunity? Are we looking at variation in readmissions or cost, length of stay, complications, mortality? All these things could be useful because it's important, again, to tie cost to outcomes. We can't look at these things in a vacuum. And so the process could be performing a provider level comparison, maybe looking at cost per DRG, or looking at medication utilization patterns by provider, or looking at outcome variation by provider. All this will then provide you some internal variation, identified but potentially internal variation that you could then feed back to that team to see if maybe this is a call to action. Maybe we need to get something together to create some more standardization or criteria for what we consider appropriate and not. The next level is then to compare, instead of internally looking at provider to provider, it's more looking at maybe hospital to hospital or service line to service line outside of the hospital. And so sources of data could be GPO. We use Vizient, and we use the Vizient CDBRM, Clinical Database Resource Manager. But again, like I had mentioned before, you could use the Advisory Board Hospital Benchmark Generator, which could give you really insightful data for your Medicare population. You can perform, again, the benchmarking for the health system, hospital, or you can do this based off of national benchmarking. The data, again, you could look at the same endpoints: utilization patterns for a drug, readmission, cost, length of stay, complications, morbidity, and you can do this at the DRG level, you can do this at the diagnosis level, you can use this at the medication-specific level. But all of this, I think, is going to allow you to develop a priority scoring system to hopefully assign weight to each outcome. That will allow you then to be able to prioritize and break down where maybe the opportunities lie within specific cost centers, and we'll talk about how these vertical approaches can sometimes evolve into horizontal initiatives. But ideally, if you do find some consistency across maybe some care variation, this might be a reason to update protocols again or develop a pathway or just get a team together to work through some challenging decisions. So here's an example of, I know this is a little chaotic and abstract, but on the left side you see the savings potential on the bottom here, looking at various drug classes, and on the outpatient, on the y-axis you have inpatient spend. And so what this allows you to look at is, okay, perhaps we did a benchmarking and we looked at the class of medications for antithrombotics for PCI. And you find that we currently spend maybe this pink dot all the way up at the top, but maybe our benchmark group is spending $100,000 less than us. Well, maybe this is one that you want to focus on because we're spending a lot of money on it, and it appears that there's some decent opportunity for utilization. The other approach, so this is kind of more around specifically benchmarking against medication utilization. When you try to start to benchmark at the DRG level or diagnosis level, there's a lot of different factors you could look at. Whether or not perhaps your institution participates in a value-based program like OCM. Maybe this is something that's really important from a leapfrog or Medicare STARS rating perspective or U.S. News and World Report. Maybe this is something that's really important from a length of stay capacity perspective or outcome from a mortality or even volume perspective. And so all these different inputs are going to feed through a prioritization matrix, which I'll show you on the next slide that we use. And this prioritization matrix should help you be able to sort through all the different opportunities that might be there and allow you to focus on maybe just a few to get started in this work. And so this slide is basically our prioritization matrix that we use at University of Chicago. And so on the top bar, you can see on the right side, patient volume, capacity and direct cost, quality and safety, reimbursement, and then strategy and reputation. Below that, you have the weight that's relative to each of these categories. And so patient volume or capacity within each, or patient volume or census within each of these DRGs contributes about 10% weight. And you can see this breakdown by service line. Ideally, not to say that 9 patients is any less important than 60 patients, but if you're trying to think about how to prioritize, you'll have more of an impact potentially on a larger patient volume service line. Capacity and direct cost has inputs that include length of stay variance. This could be benchmark compared to what do our peer hospitals perform and how do we compare to them, or it could be observed over expected. What does our documentation think that we should be at, and what are we actually doing? And you can just create an index for both of those. Or you could look at direct cost, right? So this could be what is our peer hospitals spending on average for this DRG compared to us, or it could be what are we kind of expected to spend and what are we actually spending, so that ODE again. And again, putting this into an index could be helpful in terms of weighting. Quality and safety, so this could be things like mortality index, this could be complications index, and this could be readmission index. There's ODE for mortality and readmission. Complications, you'll have to benchmark against that to figure out that index. Reimbursement kind of gets to more around what is the opportunity within, say, a managed care plan, or what is the opportunity within a value-based reimbursement program like OCM, if your organization is part of something like that. This might get further weight because there may be some dollars from a reimbursement or from a reimbursement perspective. And then the last is strategy and reputation. Is this aligned with our clinical effectiveness scorecard? Is this aligned with what we consider the organizational goals or mission? Are these things aligned potentially with moving a service line into the U.S. News and World Report top 20? Perhaps this is something that we would want to focus on more if all these other things are neutral. So I'll go through a little bit around these next slides around how we, from a structural perspective, do this and with what high reliability is. And then I'll end with how these vertical strategies can kind of flip or morph into horizontal opportunities and how we can create a culture of high reliability. So at the University of Chicago, we are on our journey of probably about 4 or 5 years now of becoming a highly reliable organization. And ideally what this team is made up of expert support and resources that includes analytics, behavioral change strategies, implementation scientists, clinical documentation improvement experts, clinical informatics, information technology or IT, process engineering, and quality improvement. And the goal really is to identify a clinical team, make adherence easy, and then monitor performance, feed that information back, so we can continue to have this culture of quality improvement. And so we do that by getting that team together to define what we consider perfect care. What do the guidelines say? Or what, if there is an absence of guidelines, what's our consensus in terms of what we think the right thing is to do? Once we define that perfect care, we deploy an implementation strategy, whether that's developing a pathway and figuring out how we're going to disseminate that information, or maybe that's creating some sort of clinical decision support tool that can aid in decision making. But the important thing is that this implementation support should make adherence easier. And then lastly, just measure and improve. See how we're doing, what do we expect to do, and how are we actually doing. So why clinical pathways? Well, clinical pathways are just one method of integrating evidence into local healthcare settings and structures, and can be a really useful tool for bridging that knowing-doing gap. Like I said before, it takes about 17 years on average for evidence to kind of make its way into routine care. And so how do we shorten that? And so clinical pathways really are just a document standard and an educational tool that can provide some level of predictability in the process, whether that's a care coordination perspective. Again, if we're developing a pathway, this is cross-cutting against pharmacy, nursing, supply chain, radiology, laboratory. If the process is more transparent, everyone knows what they're supposed to do, things become more efficient. It's also a valuable tool for addressing unwarranted care variation. And so by providing a roadmap, hopefully you can reduce that cognitive load or energy by about 80%, which allows providers to then reserve their cognitive energy for those really complex care situations. And so, by their nature, they're not a recipe, they're not a cookie cutter approach. They're really just a structured document that allows you to walk through decision making while caring for a patient or condition. And so, again, they're addressing this highly dependent, kind of fragmented current state at the local setting. This facilitates variance management. This supports multidisciplinary care. This supports evidence-based practice. It allows for redesigns of workflows and providing education and training, and it allows documenting, monitoring, and evaluating variances. And so there's a framework our Chief Quality Officer, Craig Umscheid, done a fair amount of work in this area and developed a framework for how best to develop and disseminate these types of pathways. And so ideally you should have somebody, you should identify a clinical stakeholder. Ideally this is a provider when you're designing a condition-focused pathway, who's a content expert and has pull within their department. That individual then will get a small group of individuals together to kind of recruit stakeholders. That small team then is going to conduct a rapid review to see what the existing guidelines are and pathways, and from that information develop a prototype pathway. You then get all the stakeholders together and review that pathway. Again, that might lead to another rapid review of the literature around specific decisions as feedback is incorporated. And then ultimately figuring out how do we allow this pathway to provide asynchronous feedback from the end users. How do we make sure that we have quality assurance and that we're finalizing the content and that we have the appropriate metadata, whether that's an outcome or a process measure, and developing messaging strategy for dissemination, and lastly, again, monitoring utilization and update. And so here's an example of a clinical pathway. We've moved now from static pathways, which are very effective, which is just honestly a PDF printed off, and you can see it's not meant to read here, but each of these boxes is really a decision-making tree around, does this patient have this, then they should be having these tests. And so this is really just representative of the consensus around what the considerations are for caring for this patient. What we've been able to do is actually integrate these static pathways now into an actionable pathway where providers can actually click into these boxes and it links to the orders. And so again, it's going with this culture of high reliability where we're making adherence easy. The last thing I want to talk about in this section is around the evolution of vertical to a horizontal approach. So this is an example with some fake numbers in here that we pulled this past year at the University of Chicago. So, our number one opportunity when we looked at DRGs by cost center, we sorted basically all the cost centers or had this total spend for each cost center by DRG and basically sorted the pharmacy column. And the number one opportunity was septicemia or severe sepsis with mechanical ventilation greater than 96 hours. So your next question is, well, what's driving that spend within pharmacy? And so you can drill down within these different benchmark tools to get to the specific resource. And what you find, what we observed is that calcitonin, it's strange because that's not a drug that's used for sepsis. So this must be some overlapping condition, hypercalcemia, maybe of malignancy, that's contributing towards the overall spend for sepsis. We already had this on our high cost list. And so this is just more ammunition to say, well, we need to actually do something now around the utilization for calcitonin because it appears that we're using it far more than we would expect. And so analyzing the data by cost center, identify where the majority of the cost is coming from, assess if there's an opportunity for standardization, and then form a team, an interdepartmental team to make adherence easy, develop the criteria, and then hardwire it into a pathway or an algorithm. So I'll turn it back over to Sam to focus on horizontal approaches for cost savings.
Thanks, Randy. Now that he's covered kind of that vertical approach or the more global approach, I really want to narrow our focus into specific strategies within the pharmacy department and how to target spend for specific medications. And I saw one question pop up in the Q&A about reducing vasopressin drug spend for inpatient spend specifically. And hopefully as we go through these next several slides, you'll have some key takeaways to help with a project like that one, really focusing in on a medication that's popping up on your high spend list and digging into maybe the causes of that high spend and how you can curb that use. There's really four main buckets that we think of when it comes to pharmacy cost reduction strategies, and we've listed them here along with some of the high-level overview of how we may identify opportunities within each of these buckets. So looking at utilization management, this is just really making sure that we're using the right drug for the right patient, kind of in the right steps of treating a given diagnosis or indication. So you might do this by some of the strategies that Randy spoke about, like benchmarking, by DRG or drug, looking at prescriber and dosing variations by service lines, looking, just to our staff to bring these kinds of initiatives to us, or consultants, your GPO specific software you might have, to really help surface where there's utilization opportunities. And then you might implement an audit of high-cost drugs at your institution. We put an example here of drugs that cost more than $10,000 per dose. But really, whatever makes sense to your institution, you can start running a regular audit of what you would consider to be high cost so that you could dig into that. And we'll go into that process a little bit more, but make sure utilization itself is appropriate. The second bucket, looking at low-cost alternatives. So really honing in on the value equation that Randy spoke about, of course maintaining excellent outcomes, but also then next looking at cost. Can you maintain those outcomes with a different alternative therapeutic agent? So this certainly is driven by formulary and the P&T committee, but also making sure that there's compliance with those initiatives that have passed through P&T. Looking at biosimilars, generics, IV to PO, and certainly site of care administration, specifically trying to shift utilization from inpatient to outpatient and maximize 340B contracts where possible and where appropriate. The next thing we'll look at is WAC or non-contract spend reduction. This oftentimes is going to be identified by your purchasing manager, perhaps looking at wholesaler reports to look at the percent WAC spend or wholesale acquisition cost spend for a given medication. And then lastly, we'll briefly touch on contracting. It's a little bit outside of what we want to focus on today, but we did want to provide a few examples of how you might be able to further optimize your contracts for specific drug therapies. So when we really think about the horizontal approach overall, I'm going to dive into each category, but I want to emphasize the importance of identifying the cause for specific spend of a given medication or class of medications. For instance, if you look at this chart to the right, this is one that I often use when working with clients to help identify causes of high drug spend. So imagine that your team implements a cost-saving strategy over the course of a year, and it's illustrated here. So you look at spend before that year of implementation and then the following year afterwards, and you see nearly $1 million in savings. So that's definitely a win. However, if you look a little further into each of the categories that we're discussing today, you'll see that while the price impact, that first column is showing a savings and a decrease, meaning you're optimizing your contract and the price per item, and you're also seeing volume impact showing a savings, so meaning your overall utilization of the drug and how many patients are receiving it is decreasing. Those two things actually led to a cost savings. However, the mixed impact in the middle of this chart, and when we talk about a mixed impact, we're talking about within a group of drugs that could be used for an indication, are you using the one with the greatest value, great outcomes, but lowest cost? And you can see in this example that spend actually increased. So if you really dig in deep into different initiatives and things that you have going on throughout your department, you can see perhaps there's another $1 million to save here just by using a lower cost therapeutic alternative. So I just want to take a moment to outline the importance of not assuming that because there's savings that you're already realizing that there's not more opportunity on the table, and it really goes into digging into each of these buckets for given medication. So overall, the sources of information that we want to tap into with our horizontal strategies are looking at distributor or wholesaler reports, especially looking at those that are breaking down GPO, WAC, 340B, all of those purchasing prices and percentages. The health record data, so your EHR data you'll need, your claims data, and if applicable at your site, 340B management software. From these sources, we're going to want to pull data including, med use evaluations, overall just looking at, the different components of med use, the dosing, whether it's appropriate for a patient, the duration of therapy, so on and so forth. 80/20 reports are very common, so you can get this, from various sources that we discussed, but looking at, what are the drugs that month after month are hitting our top spend. Also looking at WAC versus total spend ratios, looking at denied claims in your rev cycle reports can also be very helpful. So just getting all of this data together as you start your general approach. And as far as what that process looks like, first, developing criteria for review. So we're talking about a lot of sources and different data types here, but what is going to be key for you? And oftentimes it depends on the resources that you have available to you. What data sources do you have, and start there. So maybe you're going to do top 20 drug spend every month or every quarter. Maybe you're going to pull a report of medications where you're spending more than 40% on the WAC account as an example. So what criteria do you want to review regularly? Then you want to share that information with frontline staff. For the service line, it's most relevant to every medication, because one thing I've definitely found is that not all frontline staff are aware of pricing, and that transparency can really help. Sometimes just letting providers and letting clinicians know that medication A is much more expensive than medication B can really change prescribing behavior. The next thing is engaging both clinical and operational staff to determine the likely cause of spend. And we'll talk about that a little bit more, but sometimes these are way beyond therapeutic interchanges or clinical considerations, and really needing to shore up operational functions. And then lastly, really just making changes, whether it's on the clinical and or operational side, based on what you find. So when we get into utilization management, one of the first buckets that we see, when we think about the potential causes of waste in this area, we think about unwanted therapy selection variations within an indication. We think about dosing variations, duration of therapy variations, and so this is oftentimes where a lot of resident, student, or clinical pharmacist MUE projects come from, is really looking to see, are we using this drug appropriately? Not only are we selecting it for the right treatment or the right patient population, but what is our dosing appropriate, and are we treating them with the correct duration of therapy? Sometimes we'll see certain infections that should be treated for 5 days, but that therapy is going on for 10 days. And we want to make sure, to Randy's earlier point, that we're doing a guideline reconciliation in order to make sure that leading practices are being followed and that we're not losing or seeing waste in the value of healthcare that we're delivering. So we'll be able to get this data, internally from our EHR, externally also from GPO, advisory board, and other examples that Randy shared. And a great strategy to really improve in utilization management would be establishing a regular report cadence. Oftentimes this will be prescriber level utilization data if you're really wanting to do internal care variation reporting, or you can certainly go through your GPO or other resources for external benchmarking report as well. But you want to have a regular cadence of this information so that it'll help you identify areas of care variation. Of course, as Randy said, engaging stakeholders early on is very important, and developing those high reliability pathways, or the restriction criteria going through your formulary system. If you look at the right, you can see an example of one chart that I pulled for a client with local anesthetics. And so this is just looking at internal variation. So you have your providers. We looked at just the orthopedic surgeons and their prescribing data. And you can see there's a lot of variation here, where some providers are using Exparel, which is significantly more expensive than the plain bupivacaine or bupivacaine with epi. Some are using almost all ropivacaine for their cases, also a little bit more expensive than alternatives, not as expensive as Exparel though. And just by seeing this variation, it's very insightful, because then we can talk to the second provider on the list about why ropivacaine is their go-to agent. We can talk to the first provider on the list and ask why in more than half of cases is Exparel necessary. And then just as importantly, talk to the last provider on the list saying, it looks like you're being successful with just using plain bupivacaine in most of your cases. Can you talk about that thought process? And so just having that insight can really help to have those conversations. Then if we think about lower cost alternatives, that second bucket, again, there's potential causes of waste here. So care variation, of course, is one here. You'll hear that oftentimes from us. Another one is a backlog of formulary review. So we're seeing drugs come to market at just an unprecedented speed, and so many more in the pipeline. And it's hard sometimes for all P&T committees to keep up with reviewing these new drugs to market, the new generics, therapeutic alternatives, whatever it might be. So having, of course, an efficient P&T process and a way to kind of wait, like Randy had talked about before, what you want to prioritize in your review is key. Drug shortages is something that oftentimes is out of our control, where we're needing to pick a higher cost alternative just because that's what's available. And then lastly, the site of care that I was talking about. So, really looking and seeing, is there an opportunity to shift from inpatient administration to, delaying that therapy to outpatient settings without there being any impact on outcomes. So, of course, you want to routinely assess options for therapeutic alternatives within each indication, determine the cost difference between the agents that offer similar outcomes, and then implement the formulary strategies and pathways to lower cost of care whenever possible. If you look at the example on the bottom right, this was a project that I worked on with a client at a hospital for inpatient use of IUDs. And you could see we have 3 agents here that they had on formulary, and a couple of them were much more expensive than the other. And it's the same medication essentially, the same active ingredient, similar strengths and all of that. And so we looked at 2 things here. One is, do we need to be placing IUDs in the inpatient care setting? as often as we are, or can a lot of that be shifted to outpatient? So just that in and of itself could help significantly. But then the second thing is choosing the right inpatient formulary IUD. Given that these really don't have a lot of difference therapeutically, we were able to shift to a cheaper option and save several $100,000 a year just in making that change. So again, looking at it from multiple facets. For WAC reduction, this is really now shifting more from clinical considerations to operational considerations. So if you look at the causes here, oftentimes it's a missed drug charge for an administered med. This is common in the OR where they're using trays or kits, things of that nature. Oftentimes wasted and expired meds or purchasing above inventory needs. So all again, talking about waste of medications. Another thing would be maintaining the NDC crosswalk, which I know this is much more of a technical consideration, but one that I feel is often overlooked. If there's a mismatch in the particular product that you're dispensing to a medication and what's being loaded into your CPOE system versus what's being administered or scanned when it's given to a patient, if those aren't aligned, well, then you're oftentimes going to hit your WAC account instead of optimizing your other contracts. And then, of course, delays in accumulation for some of your contracts. So, like I said, these are more technical, and that's why the data that you're looking for is coming from wholesaler or GPO information, your 340B management software, if that applies to you, and then your EHR, of course, to look at the NDC crosswalks and everything else. So because this is so technical, our strategies for this is somewhat different as far as who you want to include in these conversations, but very important to have this discussion. So one is identifying if the cause is due to technology, med use processes, or inventory control, because those are the three things that really feed into the potential causes that we're talking about. And so you really want to have a standardized reconciliation process for drug charges in those areas that have different med dispensing processes. The OR, again, is a great example of this because it often doesn't follow that typical dispensing process. Perhaps having a pharmacy student or resident almost trace or follow the dispensing process of a medication through your OR could be very enlightening if they mark down what happens from A to Z when a med is needed in the OR, and you'll oftentimes find out why drug charges are not being captured, why you're spending so much in your WAC account. Other opportunities, especially when we're talking about wasted medications and all of that, is dose rounding, using unit dosed formulations when you're dispensing ready-to-use formulations. Sometimes they're more expensive to purchase per item, but if you're having a significant waste issue that you don't feel that can be easily corrected with changing your operations, whether it's in the IV room or at site of administration, then sometimes you'll see that ready-to-use products could be more beneficial to you. Concentration changes. And one thing that we see often is preparing meds just in case, which happens in the OR. Vasopressin is a great example of this, and I know that was a question asked earlier, is we noticed in our ORs, first of all, we were spending a ton of money in our WAC account for vasopressin. When we were able to drill down to why that was occurring, we found out in the ORs, vasopressin was being pulled up into syringes from vials just in case it was needed. And when we were able to talk to the providers about the financial impact that was having, just that discussion alone, they stopped that practice and we were able to save hundreds of thousands of dollars a year immediately. So very simple change with very significant impact. But overall, what we would suggest is developing a WAC reduction committee to review these different reports regularly and making sure to include your purchasing, your informatics, and your finance colleagues to really be able to target these discussions. And then the last part is contracting. So with this, this is kind of self-explanatory, but what we just wanted to share is there's a lot of opportunities out there. So if you have a drug that is high value, yes, it's expensive, but it's necessary, it has a niche area of treatment, whatever it might be, there's the next step then is saying, okay, we can't reduce utilization or anything else. This use is appropriate, but there's things out there like limited warranty programs where, if a patient does not meet certain clinical criteria, the drug company will actually replace that medication for you for free. There's market share rebate opportunities. There's vaccine market share discount programs. If you hit certain targets, this % of patients with this disease state, if you vaccinate them, will give you this rebate. And along those same lines, population health rebate programs. So what we would suggest is just if you see a drug that's high cost but also high value, connect with your wholesaler, your GPO, the manufacturer, just to ask the question if there's special pricing programs available for that medication. All right, that was a lot of information. I'm going to turn this over to Randy to end off the conversation for today.
Okay, thanks, Sam. Just want to make sure I save time for the end, so I might go through these a little bit quickly, but I think just provide some tips and tricks. Remember, as I talked in the beginning, healthcare is always in this constant cycle of plan, do, study, act through quality improvement. So making sure when you're bringing information to providers that we're leading with data, that we're discussing best practices or maybe leading practices within other health systems, ensuring that the discussions are focused on value-based, not cost-based. That's a quick way to alienate frontline providers if you just only focus on cost. Always question the status quo, and then pilot. I saw one question around how do you reconcile disagreement around outcomes for providers. This might be a good example of one technique you might use around piloting, seeing, well, if one person's really set on doing this, is there an opportunity of maybe doing this for a subset of patients? Maybe not everyone needs to get that, and then start to kind of move the utilization a bit. Can't talk about implementation science without the Transtheoretical model for behavior change. And so just briefly, this was developed many years ago, basically comparing smokers who quit on their own fruition versus smokers that were in a program. And basically, the bottom line is that people aren't going to change unless they're ready to do so. And they need to move through these different phases in the Transtheoretical model from this know, maybe, prepare, do, and keep going. And so making sure that you lean into cognitive dissonance, understanding that it's a healthy thing to be uncomfortable, or it's normal to be uncomfortable, but that discomfort kind of leads people to action, and that action hopefully leads to a better outcome or feeling better. And so going through these different stages, understanding that various service lines may be at different levels within this, and your organization may be at different levels. And so starting small, starting with pilots, getting people comfortable with the process is one way to kind of get the process or to get the projects moving. And then the last thing in terms of how to make sure interventions are successful in changing behavior. Oftentimes I'll hear people just say we're going to do an in-service. Those are great, but they're not sustainable. And so always knowing that education should be tied to something else, whether that's practicing audit and feedback, whether that's augmenting decision support, whether that's providing incentives, maybe not monetary, but maybe just recognition. Or maybe it's a combination of all these things with a multifaceted approach, and knowing that the more that you include, the more likely sustainable that will be from a behavior change perspective. So key takeaways here, just assess your organization's resources and capabilities to determine the best approaches. Start small. Things that may seem like a small project will evolve and cascade. You'll get engagement from that group by leaning into that cognitive dissonance. Engage with key stakeholders early to identify causes of low care. Maybe that's with your frontline pharmacists. Maybe that's with providers, sharing this at the P&T subcommittees. Consider clinical and operational solutions. Look at yourself in the department and see if there's opportunities for driving value beyond, making sure that you're driving value going beyond just cost and emphasizing outcomes. And then lastly, just making sure that you're establishing metrics to audit and provide feedback. High visibility and peer comparisons go a very long way in making things sustainable. So with that, I wanted to open it up to the audience for any questions if we have time.
Thanks, Randy. And I see, too, that it looks like we were able to answer a lot of the questions throughout our presentation, which is why we're at time. What I'll say to the audience is if we'll go through the rest of the questions, and anything that we weren't able to answer as we were going through, we can certainly follow up with you by email with an answer to your question.
Excellent, and that is all the time we have for today. I want to thank Dr. Bastow and Dr. Knoble for their excellent presentation, and Lumiere for sponsoring today's webinar. Enjoy the rest of your day, and we look forward to having you join us for future webinars.